Good evening, everybody, and welcome to this Stride Workshop, part of Positive East Staying In Together programme. Tonight, I'm joined by Simon Rackstraw. Dr Simon Rackstraw works as a consultant HIV physician at the Royal London Hospital in London, where he runs a specialist clinic for patients with HIV-related neurological disorders. And he's also the medical director of Mildmay Hospital, which is the only dedicated inpatient rehabilitation unit for patients with HIV-related neurocognitive disorders in Europe. He's also an honorary senior clinical lecturer at Queen Mary University, London. Simon, it's great to have you with us. Good evening.
Good evening. Thanks
for joining us this evening. So tonight we're going to be looking at the links between HIV and dementia, and I believe that you've got some slides that you've prepared for us to talk us through what we need to know about this very important subject.
Absolutely. So we'd like me to share them with you now.
Ready when you are, Simon.
Okay. So one of your colleagues actually asked me to help deliver this and had some thoughts about what we might be talking about in terms of the links between HIV dementia and sort of things that people might want to think about that might be helpful in terms of lifestyle changes and other things that they might be able to do to reduce the risk or to be less worried about it. So I'll proceed. All right. So the problem with cognitive impairment is that it often induces this kind of thought process. You know, it's a difficult subject, and what should we do about it? So that isn't a picture of me, by the way. And this was the study that I think was also shown on AIDS Map that was published earlier this year in a journal called AIDS, which was a big research study conducted in the United States, where they looked at their database of people registered with Kaiser Permanente. And Kaiser Permanente is, if you don't know about it, is a bit like a sort of a kind of a mini NHS in certain parts of the US, but paid for by health insurance. So they looked at their database and they compared about 5,000 people who were living with HIV and about 120,000 people who were living not with HIV. And as you can see, I've put the headlines on the slide here. And a significant number of people by the age of 80 have been diagnosed with HIV. So more of the HIV, more with dementia. So more of those living with HIV than those without HIV. They then did an adjustment to look for things that we know influence the risk of you getting HIV, getting dementia. And when you adjust for that, there was still an increased risk in the patients that had HIV developing dementia, despite being on good antiretroviral treatment. So that's clearly a little bit of a worry for some people. So what I thought I'd do is have a quick look at why this might be and whether we should be worried about it. It is, of course, a single study, and it is, of course, conducted in the United States, and things are a little bit different there. The first thing to think about is that actually dementia is getting more common amongst everyone. So regardless of whether you have HIV or not HIV, the numbers of people with dementia are increasing in the population at large. And most of this is about the fact that people are living long enough to get it. So if you can look on this graph, and you'll see there's the lines for sort of older age are gradually getting a bit bigger. So the numbers of people projected to have dementia in 2051, and this was a study done for the Alzheimer's Society over a number of years. You look at the increasing from 2005 levels of about 600,000 up to about 1 million more than that by 2051. So it's going to become a more common problem for health services to deal with. Now, there are many reasons why there might be an issue with patients who have HIV being at more risk for problems with their cognition. So I'm going to look at just to talk you through this slightly strange looking graph. So we've always known about, and I'll explain a little bit more about this before, that HIV itself can actually cause dementia or cognitive problems, particularly when people are not taking antiretroviral therapy. And this is due to the virus activating or replicating within the brain, and also with inflammation going on within the brain. But there are other things that can also be causative in terms of having problems with your cognition. So, for example, some brain damage that could have happened before you started taking antiretroviral therapy, the fact that you are getting older and the risk of cognitive impairment is going up, the fact that people are more likely to have problems with their hearts, which can also interact with what's happening in your brain, the fact that people have maybe misused alcohol or drugs over a number of years, and also the potential, which, and this really isn't very clear yet, for some drugs, potentially if you take get the concentrations wrong, antiretrovirals, to cause some toxicity on the brain over the long term. So probably what is happening for some of these people is a sort of combination of different factors. But I don't think we need to worry too much that there's going to be a sudden horrific descent into dementia amongst all patients with HIV. So I was going to put some things together and think of 5 quick points to consider regarding cognitive impairment. Now, there's a few sub-points amongst this. So the first thing that's important is to be aware, okay? So being aware that there is a risk that this could happen, that there is a risk of many things happening in life, but one of the things that can happen in the context of HIV is that you can develop some cognitive problems. So I'm going to go back, this is a very, very long time ago, long before many of you were perhaps even aware of your diagnosis. This is the original definition in 1987 of a dementia or an encephalopathy caused by HIV, as kept on file in the CDC, where they define these things. And it really talks about people having problems of which are disabling, of cognitive and motor dysfunction, which interfere with their activities of daily living, which are slowly progressive and caused only by HIV. Now, the thing that's always interesting and dates this very much to 1987 is that, as if you'll note, the last words in the definition is one of the ways that you diagnose it's an autopsy. I think we've probably moved on a little bit further than that now. One of the important things to think about in terms of cognitive impairment is that actually patients are getting older, okay? So not only are some people being diagnosed at older age, but a lot of people are staying well with their HIV, and therefore they're living to an older age. I certainly remember when I first started looking after HIV patients, pretty much everyone was sort of in their 30s, and there weren't people that were older. Now you can see a significant proportion of the patients under care in the UK are certainly over 50, and an increasing number over 65. So as I always say, patients are getting older and the doctors are getting older. The other thing that's important is, and this is a thing called the Continuum of Care, and this is a graph from the UK comparing it to the United Nations AIDS 1990 targets that show that how many people, of all the people that live with HIV, and then those who have had a test and know they have HIV, with those who are on treatment, and those who viral is undetectable, that we actually do quite well in this country. So you can see 89% in 2009 of all the people with HIV in the UK were undetectable, and that's slightly better even than the target of 73% that they've set worldwide. So that's one of the reasons that patients are living longer, and if you like, living long enough to get things that perhaps they didn't previously think that they would live long enough to have as a problem. This is just a quick study showing that this was done across all of Europe, looking at patients attending various European outpatient clinics. There were about 500 patients attending a variety of outpatient clinics across Europe, and looking at patients that might have had some cognitive problems, About 35% of patients were found on testing to have some cognitive problems, maybe a bit mild, of whom 17% of those, so about 6% overall, had said that this has influenced what had happened in their abilities to do things in their daily life. So they've had a decline in their ability to perform tasks that they do on a day-to-day basis. Just as a matter of usefulness for you to know, there are standards that were developed. I was involved in the committee of doing this way back in 2011, so that all patients living with HIV should be able to access psychological support and interventions for their cognition to the same standard across the country. And these were standards that were written up to be national standards between the British Psychological Association, Pituitary Association, and the Medical Foundation for AIDS and Sexual Health. And they basically suggest that there's a complex model, which I'm not going to go into elaborately, but everyone that people come into contact with should be able to provide some support. And then clearly, as things get more complicated and if people have more complex needs, then more specially trained people should be delivering those interventions to help people and provide support diagnosis. If we go to the particular point with regard to cognitive difficulties, so problems with thinking, the standards suggest that everybody should have access to screening for cognitive difficulties early on after receiving an HIV diagnosis, and then they should be able to have access to this being repeated following difficult events, or at least annually, should they so wish or feel it necessary. So that should be available in any clinic you're attending. There's various ways of doing it. There's all sorts of ways of doing it. I'm just showing you this picture of one of the bedside tests that we use when people are in hospital. So you've got to be able to draw the dots the right way, draw a cube, draw a clock, the right time on it, tell me what these three interesting animals are, and then a few tests of memory and some sort of things about thinking about numbers of words and being able to put numbers backwards and forwards. It looks quite complicated, but most people do fairly well. And it's quite a useful bedside test to see where things are going wrong if we have worries about it. But you can do all this stuff really simply now. You can do it on your smartphone. There's an app for this, and you can just do it while you're waiting in the waiting room or on the bus. So technology is moving things a bit forward. I think the most important thing that came out of the standards was that actually that people living with HIV should be given the opportunity to talk about how they're feeling with professionals providing their health and social care, because patients often state that people just don't ask about their mental health. They're asked about, are you taking your tablets? What's your CD4 count? Have you had any problems with your health? But more physical health rather than mental health. And that's often the thing that patients want to talk about. The next thing I'm going to say is reassure, and it really is. I think sometimes we see these headlines that oh, we're all going to get dementia, it's all going to be terrible, and I think it's probably not the case for the majority of people. So I'll put on this list here some symptoms of mild HIV-related cognitive impairment. So I'm just going to give you a few seconds to sort of look through. So things like difficulty concentrating, having your thinking that's a bit slowed, not remembering phone numbers, using lists to keep a track of things, feeling a bit irritable or a bit depressed. And you can see that actually these symptoms of very early cognitive problems are actually symptoms that a lot of people have every day, and particularly sort of, a bad Monday morning or another dreary day during coronavirus, probably not. So they're not very specific for diagnosing cognitive impairment. It's a quite complex way of looking at this, so I'm not going to go through this in elaborate detail, but the point about this is that there is a sort of medicalized way of determining whether some of the problems that people describe in terms of their thinking and their ability to do things fall into categories, and most of these are not the category at the bottom, which is called the HIV-associated dementia, which is now becoming increasingly rare. Most people have what is, if they're going to have anything, is probably the mild neurocognitive disorders or the asymptomatic neurocognitive impairments, which are much milder and don't impact so much on what people are doing on a day-to-day basis. I've talked a lot about cognitive difficulties, and I think it's just worthwhile just having a quick look at the sort of things that we measure as doctors when patients complain about cognitive problems. So when people come to my clinic and they say, oh, I'm having some problems with my memory, which is actually what people tend to say, memory tends to be a sort of catch-all way of thinking, I'm not quite as good or sharp as I once was. But there are lots of different bits that may be not as perfect. So if we look at this was a study done in the United States, and you can look at before antiretroviral therapy was widely available, people used to have problem with word finding. They used to have problems, taking in information in a quick way. They used to have problems moving, so they were slow in their movements. Their motor skills were low. What people tend to complain of now are maybe problems learning newer things and what we call executive functioning. So like, if you like, the chief executive of your brain, the decision making from the top, doing things, multiple tasks at the same time. Those are the kind of problems that people sometimes complain of these days. As I said, not all dementia is HIV related. Some of it can be things like Alzheimer's disease. They tend to be slightly different things that present. So people with HIV related problems are a bit slower, maybe have difficulty making decisions. With Alzheimer's disease, just forget things more often and often get lost. So, they will go to the shops and not remember where they've gone, and that tends to be more common. So there are some ways of differentiating from things depending on how people present. The reason it's important, I think, is that to pay some attention, particularly as a doctor, to when patients complain about these things, is they can impact on your ability to do things. So people with significant problems with cognition can have problems taking their medications. They can have problems preparing meals or looking after their money. They're more likely to complain of problems working, or more likely to be unemployed. And they're also more likely to fail driving tests, should they do them. I'm just going to take you very, very, very briefly through this study which we did, which I did at the Royal London Hospital, and it was also done in combination with colleagues at Whipps Cross, Newham, and St Thomas's and Guy Hospital. And we tried to do a fairly brief set of testing for neuropsychological difficulties, and then we put it together with details that we knew about what patients' lifestyle was like and what drugs they'd been on, to try and find out, was there some evidence of problems with thinking in our cohorts across East and South London. As you said, we did quite a lot of tests. We did 710 tests. The average age of people was 46. This was done mainly with computerized neuropsychological testing, and as you may expect, boys like playing with toys, and so more people were male. Slightly more people were white than we see in the clinics generally, and actually less people had an undetectable viral load at this time. People had fairly good CD4 counts, although the lowest point that their CD4 count had been was actually still fairly low. And up to a third of people demonstrated some impairment, not necessarily in all areas of their thinking, but some problems in thinking in one or two areas of their life. Just to explain to you, in this study, we found that people that were very anxious, people that had not had as good education, that were diagnosed for reasons other than men having sex with men, and were more likely to be associated with having some impairments. And there can be many reasons for this. Some of these tests are not very well validated in amongst people of different ethnicities or backgrounds. There are no different particular antiretroviral regimens associated with impairment, but there's this score that looks at the number of drugs that get into your brain. So patients that were on regimes with high scoring regimes were more likely to have some cognitive impairment, and that's probably about than being diagnosed with that problem and medication being adjusted accordingly. So it gave us some insight into what might be going on, but also posed a lot of questions at the end of the study. One of the other things that I think is probably important before people start to get too anxious about things is this study, and this is a quite interesting study that was done in the US, and they looked at the number of people that were complaining of problems with their cognition or problems with their mood, and they actually did a fairly detailed analysis of whether people had memory problems, neurological problems, or whether they were just depressed. And what they tended to find in this was people that said, "Oh, I'm terrible at doing this. I can't take my pills. I'm not able to do anything." But they were over-reporting those problems compared to how they were measured, tended to be more likely to be depressed. And people that underreported it, even though they did badly, were slightly more likely to have problems with their brain, so more likely to have a sort of dementia-like picture. So that's also worth what if you're sitting at home thinking, "I'm doing really badly," it may be that actually you're more depressed and having problems with dementia. The third point on this is, I think, that you need to get treatment for whatever you can get treatment for. And so if there are issues with cognitive impairment, then we need to look at treating everything that's possible to treat and ameliorating things and making things as good as they can be. So we go back again to this little cartoon that I showed you earlier on. Some of these things are due to, we're wondering that some of the aspects of dementia might be due to active HIV, ongoing inflammation, and then some things about cardiovascular disease, drug and alcohol misuse, and antiretrovirals. I'm just going to talk about a few of these points. So the first thing is that if you've ever had a low CD4 count, then you're slightly more at risk of developing cognitive problems than if you haven't. And some of this is probably a function of when you were diagnosed. So people are much more likely these days to be diagnosed with higher CD4 counts than those not. Now, it doesn't mean that just because you have a low CD4 count, you are definitely going to have cognitive problems, but there's a slightly increased risk. So this fits in with what we were saying earlier about it may well be that there's some damage that happens if people get very poor immune systems that sets them up for some cognitive problems later in life. The one thing that is very clear in the guidelines, and I haven't updated these are the 2015 guidelines, but the most recent guidelines, they haven't actually been adjusted for the past 2 years. They say exactly the same thing. And they suggest that anyone who's got any cognitive difficulties needs to start antiretroviral therapy. So it certainly seems that if you have any cognitive problems, then being on antiretroviral treatment is better than not being on it. Okay, it's very rare these days for people not to be on treatment, because it's not just about your brain, it's about your total health, and virtually all aspects of health are improved by being on antiretroviral therapy. There are a few people that do develop some problems with virus still replicating in the brain when it doesn't replicate in blood. We see this, it's actually quite rare. This is the first description of this. These are 11 patients in Paris. They haven't been reported in any more than sort of 30 patients from any part of the world. But it is something that can happen, and if people are developing cognitive problems, it's probably something that needs to be looked at to make sure that viruses aren't, if you like, declaring independence in your brain from your blood. It's often quite easy to treat once that's happened, actually, but just by a small adjustment of antiretroviral therapy. The other thing that's important is to treat what we call cerebrovascular risk factors. So this is why when you go to your clinic or you have your appointment, hopefully people will be asking you about, did you have your blood pressure measured? Are you taking some treatment for it? If you've got high cholesterol, you probably need to have treatment for that. If you're smoking, think about stopping. All those things are not good for the blood vessels that go through your brain, and being on treatment for them certainly improves brain functioning. Also, if you have any other comorbidities, so this is a study looking at people who had hepatitis C and how their brain function improved once they've been treated successfully with hepatitis C. And again, there aren't many patients now who have hepatitis C haven't undergone treatment very promptly. The drugs are much easier to use. This is a study done from the Netherlands a few years ago, and they also look at various things that were risks for developing cognitive impairment in patients who, well, these were middle-aged Dutch men who didn't have a detectable viral load, so they were undetectable. So you can see here, maybe having problems with kidneys, having diabetes, having slightly more weight around your waist to your hips, maybe being depressed, having a very low CD4 count in the past, and very regularly use of cannabis. But you could substitute cannabis for any recreational drug in use to excess. And this is just a way of thinking about this, trying to put it all together. So probably the way that you keep sort of a healthy brain and reserve for going forward as you get older is looking at being on antiretroviral therapy, treating other things that are going wrong, making sure your mood is as good as it can be, addressing lifestyle, and also thinking about, and I'll talk a little bit about sort of psychological factors in a little bit, but all of those things together are probably what's going to be keeping your brain as good as it can be. Now, I'm slightly overemphasizing one of these points, but I think one of the things that you do need to take home as a point is that whatever's good for your heart is also good for your brain. So maybe we should be doing some joint neurology, cardiology sessions together. So all the things that you're advised to do in terms of keeping fit generally, so as in what's good for your heart, is also good for your brain and your mental health. So probably the biggest intervention that anyone living with HIV can do to improve their general health outside of taking antiretroviral therapy is stopping smoking if they smoke. It will probably increase your life expectancy more than any other intervention you can make at this point. The other thing that's important is to try and be as active as possible. So this is just one study, but any number of studies suggest that an active lifestyle is associated with better brain function. It's associated with you're less likely to be depressed. You're more likely to apparently be in employment if you're fit, but that's a slightly circular argument, I think. But certainly keeping as active as you can within the limitations of your physical health is actually very important, and very important for your mental and cognitive health. The other thing, interestingly, is that, and this also exists, this is also a pattern that's been seen in people not living with HIV, is again trying not to put on too much weight across your middle. And I think it's been quite challenging for a lot of people particularly during coronavirus, when I've seen a lot of patients that have been sitting at home getting anxious, eating cake, and put on a bit of weight. But if people can try and avoid too much obesity, it certainly has an association with improved outcomes in terms of thinking. This is probably mediated by if you put on lots of weight, particularly around the middle, then you're more likely to get inflammation, and therefore that's also going to have an impact on what happens in the brain. The last point I want to make really is about using your brain. Okay, so if you don't use it properly, then you are likely to lose functions that you had before. I don't know if anyone's ever heard of this, but it's just quite an old study now, but there's been various offshoots of it. But this was a study done called the London Taxi Driver Study. And it's important because it tells you that you can do things to change even the structure of your brain by practicing doing things. So what they did was they did some fancy brain scans and some neuropsychological tests. They did on a bunch of taxi drivers and a bunch of bus drivers in London. And actually, the taxi drivers were much better off than the bus drivers. And they also, as they continued in their taxi driving career, they found that their brains, particularly the bit of the brain that was associated with memory, got a bit bigger. And partly this is because, as you know, London taxi drivers have to do quite complicated exams. They have to remember all of the roads, I think, within a 6-mile radius of Charing Cross Station and lots of other sites, whereas bus drivers drive a single route. And so it's thought that because being a taxi driver makes your brain, or forces your brain in some ways to be more flexible, and you're sort of exercising your brain more, then this is why you can see these changes. So that's quite an important piece of knowledge to know, because it means that doing things with your brain can not only keep it as good as it can be, but also improve it, and even in size and shape. So this is just an example of a paper that's shown this, exactly this, in patients living with HIV. These are computerized brain training exercises that are done with patients, and actually they show that in patients living with HIV, then this can actually improve your speed of thought and improve memory. This is also some evidence of something similar. This wasn't done with a computer. This was done with with pen and paper exercises, so a sort of combination of puzzles and things, showing that patients that went through this program, it was about 16 weeks that people had to commit to logging in to do these sort of paper and pencil exercises. They actually showed that they got improvements in their thinking across multiple different domains compared to those that didn't actually do the exercise. I thought it'd be useful just to show you this very small pilot study that was actually done by one of the colleagues that was doing a community-based cognitive rehabilitation group actually at Positive East. This was some time back, I think about 5 or 6 years ago. People can remember those far off times when we used to meet together, not on Zoom meetings. But basically, this was a group of people that had concerns about their cognition. They were given some education about how their brains worked, HIV, cognitive function, and then there were some measurements before and afterwards. And actually, what it showed, it was an initial pilot group. It did show that people gave positive feedback on the memories, on the strategies and the material that they were given. Some people have requested top-up sessions, but those who had slightly milder impairment to start with seemed to get the most benefit out of it. So even in a small group setting such as that, there does seem to be some value in using these strategies together so that people can improve on their thinking. I'm just going to stop this or come to an end with this last point. And this was actually illustrating a model of how people cope with resilience. So resilience is, if you like, your ability to bounce back from difficult situations. And your ability to cope with new and difficult problems. And one of the most important things that was found was actually interventions that improve people's social interaction. So, having friends, joining Zoom meetings, interacting with other people is actually very important in improving your cognition and your general resilience in coping with the adversities of life.
Simon, that was a fascinating presentation. We got so much robust information there. Thank you so much for sharing that really valuable material with us. I've got a couple of questions, if I may. You mentioned about quitting smoking and losing weight. What about those of us that are sort of in our 50s, 60s and beyond who smoked and overweight all our lives? Is it too late for us?
No, I think it's too late. I mean, the data suggests that even smoking at any age, you start to get some benefit fairly quickly. So stopping smoking, I know it's a very hard thing to do. I don't underestimate the difficulty in doing it, but certainly you get some benefit from it fairly rapidly. Similarly, losing weight is probably, I think when I say to patients, you need to stop smoking and lose weight, they're probably the two most difficult things we ask people to do. So I'm not giving you any special tips on how to do it, but I think you can get a benefit from it fairly rapidly if you can manage it.
Thank you. And one last question from me before we invite our audience to come and present questions to you directly. For those of us that receive a diagnosis of HIV-related dementia, what treatments are available for us?
So it really depends on whether once the diagnosis has been done, whether you think it's just down to HIV or down to other causes. So there are some specific Alzheimer related dementia treatments that are available on NHS. They're increasingly available. They're not that good because a lot of it is a lot of problems with Alzheimer's in particular is that some of this inflammation has been building for 10-20 years. So by the time you notice you've got it, it may be a bit too late to, if you like, reverse it, but you can certainly maybe slow down the progression. With the other things that are the other common dementias, so the HIV related ones, really antiretroviral therapy is the mainstay of treatment. You can use various mood stabilizing agents, which are fairly easy to use. And clearly, if there are problems with vascular dementia, so problems with blood vessels and things, then it's really going back to looking at, controlling blood pressure, all those sort of heart style interventions. So there are treatments out there, and some people make remarkable recoveries.
So that's good news. It's not all bad news then. So really your message is clean your act up, get yourself together, and just let's start embracing a more healthier lifestyle sort of holistically.
Yeah.
Great. Okay, Dr. Simon Rackstraw from the Malmate, we're out of time. I'd like to thank you so much for coming along tonight, and thank you for the decades of care and support that you've given to our communities throughout your career. Thank you very much indeed.
Thank you.